This unit covers burns, inhalation, chemical, electrical, flame, or fire burns. Hopefully you'll be able to get to the burn unit here at St. E's and apply some of this to the patients there. On the last objective, I want you to be able to take a burn patient, ask questions of the patient, EMTs, anyone who was just at the scene, etc., and create a treatment plan for them. Some questions you may ask are, how long was the patient in the fire? What was burning? And then we'll focus more on this at the end of the lecture. So in addition to that, the other objectives are list the most common cause of burns, differentiate between first, second, third, and fourth degree burns, recognize the signs and symptoms of inhalation burns, recognize the signs and symptoms of chemical burns, electrical burns, and recommend treatment for all those types of burns. Explain the hemodynamic changes that occur with the patients that have been involved in fires, and then I've already mentioned the last objective. So these are the types of burns that patients may encounter. Scalding burn, which could be water or grease, a burn from an open flame, a burn from an electrical source, chemical burns, and inhalation burns, which involve the upper respiratory tract. The assessment for burns is basic. This is basic for any type of burn. Always, always, always check the ABCs first. What questions would you ask in the history? What caused the fire? How much smoke was there? What was burning? Was it chemicals, electrical, vinyl, etc.? Because that makes a huge difference on how you treat a patient, because it affects their metabolism, it affects their upper airway. So you always want to know what kind of material was being burned. Always 100% FiO2 if any smoke inhalation is suspected, and that is to get rid of the carbon monoxide. So those are the rest of the assessment things you can read on your own. The depth of burns or the degree of burns. First degree burns are usually dry, red, painful. I'm sure you've all had that where you've touched the edge of the stove or you've touched a griddle or something like that. Very superficial, doesn't yet blister, but it just dry, red, and very painful because it hasn't burnt those nerve endings yet. Second degree burns, usually red, wet, where they get the blisters, and very painful because, again, it hasn't gone deep enough to burn the nerve endings. Third degree burns are leathery, waxy, and don't have any sensation because they've gone deep enough to burn the nerves. Fourth degree burns involves underlying subcutaneous tissue, tendons, or bone. Very, very severe burns. Another thing I wanted to talk to you about is third degree burns may be referred to as full thickness burns. You may hear physicians, especially in a burn unit, say, well, they have full thickness burns, and they're talking about third degree burns. Second degree burns may be called partial thickness burns. So there is a difference between partial and full thickness. This is just a refresher on the layers of the skin. The first degree burn covers just the outer layer. Second degree burns a little deeper. Third degree burns deeper still, and then fourth degree would be clear down to the bone. Okay, so that's a pretty good demonstration of where the burns are occurring. Kind of gives you a visual of what area you're talking about. Continuing on the next page, pain medication. Some physicians don't believe in pain medication, but if you can, try to encourage that. Give them a tetanus shot. Do not use prophylactic antibiotics because that can kill off the normal flora that helps heal and help promote healing, so you never want to use prophylactic antibiotics. Escharotomies, that's probably a new term for you. That is when they cut the top layer of skin to release pressure from the fluid buildup or from the edema from the burn. Because if too much swelling is present for too long, compartment compression occurs, causing nerve damage and tissue necrosis. So what happens is it swells up so bad that it cuts off circulation, and the patient can't get any blood flow to the rest of their body. So you really need to be careful. If it starts to swell, the physician will come in and do some cuts. And I think at the end I have some pictures of escharotomy. So we'll talk about that again in a little bit. Usually they only do those in 3rd to 4th degree burns, and where it's most helpful is on the chest. If you have an intubated patient and you are bagging somebody and they become difficult to bag and they have 3rd degree burns over their chest, an escharotomy may help with that, release some of that tension so you're able to bag even more effectively for that patient. Okay, moving on to inhalation injuries. Signs and symptoms of inhalation burns or inhalation injuries. If they have any sort of facial burns, you must consider an inhalation burn. If they have singed eyebrows or nasal hair, perioral charcoal, if they have soot around their mouth or in their mouth, you need to suspect an inhalation injury. If they have any type of respiratory distress, and we need to monitor them for carbon monoxide poisoning. So those are some things you need to consider with inhalation injuries. They are called thermal injuries because of the heat that gets to the respiratory tract. In the upper airway, it's especially damaging, results in blistering, edema, accumulation of thick saliva, and may cause glottic closure or laryngospasms. I think in the next slide here I have a video, or next couple slides have a video of somebody that's in laryngospasm. Lower airway injuries are very rare because the upper airway cools the hot gas, so it's very rare unless the patient is unconscious and they can't fight or can't cough. It's very rare that you would see somebody with a lower airway. The reflex laryngospasm and glottic closure prevents this injury. So most of the time you're only going to see an upper airway injury. Sometimes you feel like you have an inhalation injury when you eat jalapenos, but I thought that was kind of funny. This graphic tells about it's a kind of an algorithm for inhalation burns. Carbon monoxide can cause rapid and severe organ dysfunction, and it decreases the O2 transport as well as the O2 utilization. Central nervous system and heart are primarily at risk because they don't have the oxygen. The carbon monoxide is binding to the hemoglobin, kicking off the oxygen, so most patients actually die from hypoxia because of the CO poisoning. Carbon monoxide may be 15% in minor fires and up to 60% in severe fires. I've seen patients come in with 30 to 40% carbon monoxide in their blood, and it's usually not a good outcome because their brain has been so deprived of oxygen that they have a severe head injury or they have a severe anoxic brain injury. So they typically don't do so well after 30%. Normal carboxyhemoglobin is 0 to 5% depending on your smoking history, so up to that 30% range is just devastating for the body. Cerebral edema occurs quickly, again because of the hypoxia. So you can read through this. It's an algorithm that tells you what to do if you do have somebody with carbon monoxide poisoning. Always, always, always 100% oxygen. That helps flood the membranes and get the oxygen where it needs to be. Treatment for inhalation injuries, immediate intubation is always recommended due to the quick swelling of the larynx and laryngospasms. And as always, check the ABCs first. I didn't get that on there, but always check for your ABCs first. 100% FiO2 for CO poisoning. Even if the patient's awake, they will almost always intubate to prevent problems, so don't let their consciousness fool you, especially if they're coughing up black sooty stuff. That's a good indication that they're going to need to be intubated because they're going to be trying to cough that stuff up. And a lot of times they'll just put them right on the VDR as well. The VDR is the percussive ventilator that helps shake that stuff loose, and you'll suction out tons and tons of stuff. Bronchoscopy is almost always done to determine the extent of damage. So in the burn triage room, that's one of the first things you will get ready for the physician. Hopefully they come in intubated and on 100% oxygen, but if they don't, that will be your first two jobs, and then get the bronchoscopy ready. We're moving on now to chemical burns that have been inhaled. such as chlorine. If you're near a swimming pool, you may see these injuries come in. Anhydrous ammonia is the most common chemical inhalation burn, especially in this part of Nebraska. Those of you that live in suburban areas, you may not see it, or urban areas, you may not see it quite so frequently, but here in the rural Midwest, this is what we see quite common. Usually causes acute tracheobronchitis, bronchospasms, bronchorrhea, and pulmonary edema. What happens is the ciliary transport is inactivated, so they can't get any of that phlegm up. They can't cough hard enough to get that stuff up and moving out. Again, assess ABCs first. They may order lots of albuterol treatments for the bronchospasms, and as a last-ditch effort, they may need to be intubated. So keep those things in mind. Housekeepers are prone to this. They try to get a stain out and they mix some chemicals together and it poofs up in a big cloud of smoke, and you will see some chemical inhalation burns every once in a while too from this. Okay. All right, moving on to scalds. Youch, what a painful thing. Usually second degree, blistered, red, less wet, but they are blistered. Treatment, antibiotic cream, there's not a whole lot that you can do for it. Closed dressing and Acticoat. Acticoat is a wound dressing that we've just started seeing here in the last couple years. It has highly absorbent alginate, which is made from seaweed, that helps thicken up substances, so it helps thicken up the skin, and it provides a moist wound environment, so it helps to regrow the skin. It has high absorbency and the antimicrobial power of silver delivered within the dressing and to the wound bed. So Acticoat is something that you may see quite frequently on any burned patients. Signs and symptoms are pretty obvious. You're going to see a wet, red injury. You'll take a history from the patient. You'll find out, usually they're conscious because it depends on the type of burn it was, but for the most part they're usually conscious, unless then it was an explosion of some sort and they have a head injury on top of it or got knocked unconscious. Treatment is first to determine the extent of the burn. Again, stop the burning process. Try to relieve their pain if you can. Prevent infections. Try to have them not burst their blisters, as tempting as it is for some people. Have them not burst their blisters, and then maintain body fluids so they don't get dehydrated. Okay, on to topical chemical burns. History of working with chemicals, especially strong acids or strong alkalis. The injury is usually brown or gray in color, and that's just because of the dead skin. It just kills the skin around there. And it also may take 12 to 24 hours to declare itself as severe. So you may spill something on your hand. Maybe you're working with lab chemicals and you spill something and you think you wash it off and maybe nothing happens, and then 12 hours later you have this big brown spot. It's because it took a long time to get through that first layer of skin. But other chemicals that may cause burns, cement is a serious chemical that burns people. We see that quite frequently with the road construction crews out here. They don't have high boots on, or they don't have rubber boots on, and it leaks through their tennis shoes or leaks through their boots, and it causes a serious burn because it's so alkalytic. Lye is another one, and super glue, you see that every once in a while where a kid was playing with super glue, causes severe burns to their little hands. So those are some of the things we see most commonly. I don't know, I can't think of anything else that you may see, but treatment for this: wash the area with cool water for at least 15 minutes. Treat as a deep dermal or full thickness burns using the same treatments we used before. Monitor patient for systemic toxicity, and that's where the chemical that has burned the patient is absorbed through the skin and actually causes poisoning to the rest of the body. Some symptoms for that would be lightheadedness, dizzy, vomiting, anything that would clue you in that they are toxic. And then try to treat the pain if you can. It's a little more difficult to do that, but treat the pain if you can. Immediate cardiac death is the most common cause of death after electrical injury. Like that gentleman's picture I showed you before, he did have some heart injury, but they felt like he would be okay. But that's the most common cause of death, is cardiac death. Several mechanisms of injury, massive tissue damage, explosive damage where it just explodes the organ or the tissue that is surrounding, muscle necrosis or a crush injury type thing, and heat destruction where it actually just destroys it because of the intense heat from it. This is an actual patient that I took care of at the Burns Center here in Lincoln. He got struck by lightning. You can see where it coursed right through his body. You can see the red marks. He had a wound on the back of his head, his palms, and his feet. He also had some heart damage from it as well. The electrical current caused some ischemia in his heart, but they felt that he would probably be okay. But isn't that amazing? All right, pathophysiology of burns. Again, you'll find this in your reading, but I thought this was kind of interesting. Most of the time what happens is there's a carbon monoxide production. And this is talking strictly about patients who have been involved in a fire, the flame fire, not a chemical or electrical. These patients most likely have suffered from some sort of inhalation or contact burn. Most patients who die from burns actually die from carbon monoxide poisoning, like I mentioned before. It takes up the space from the hemoglobin and the oxygen, basically causing severe hypoxia to the tissue. We covered this in diagnostics, but this is just to refresh your memory. Cerebral edema is the cause from lack of oxygen to the brain. The blood vessels swell in the brain to try to get more blood, thus more O2, and gathers more O2 and causes engorging of the brain. So that's where that cerebral edema comes from. Anaerobic metabolism is from hypoxia as well. Lactic acidosis ensues, causing metabolic acidosis at times so severe that it'll cause death. So what happens is the oxygen is gone from the cells, which shifts it from the aerobic metabolism to the anaerobic metabolism, causing high levels of lactic acid and then causing metabolic acidosis and then death usually. Early changes of the carbon monoxide production, the reduction of O2 in transport and utilization, we've talked about that, and you know that the carbon monoxide binds to the hemoglobin to form carboxyhemoglobin, and then that's the early change we just talked about. Other hemodynamic changes that may occur: shunting may increase, the delivery of oxygen decreases, the consumption increases, and the SvO2 decreases, causing cardiac output decreases, as well as the O2 content. It's in your path book too, so hopefully you've read the chapter before you've read this PowerPoint. Intermediate changes, 2 to 5 days post-burn, you may see some pulmonary edema, and that's because of the shift from the dehydration to the fluid engorgement. Reduced chest wall compliance, maybe they have some compartment syndrome, swelling around the chest. Ineffective secretion clearance, because remember the mucociliary transport system has been affected from the inhalation burns. Ineffective secretion clearance from that. ARDS from surfactant dysfunction. Hemodynamically stable if the physicians and the nurses have kept a careful fluid resuscitation. Late changes, this is maybe 5 days post-burn. You may see some pneumonia starting to occur because they don't have good clearance of their sputum or the bacteria that's growing in there. You may see sepsis. You may see pulmonary embolism because the patient has not been getting up and moving around like he should or she should. So those are some late changes you may see. This is a picture where escharotomies are usually performed. It's just to release the skin so the nerve damage is kept to a minimum. And physicians or nurses are the only ones that do this. Hopefully you will never have to do this. But they just go barely below the skin level, the dermal level, and cut that enough so that it releases the pressure. So I'll let you read this, review your notes, answer all these questions, and you will do well on the quiz or the exam. And read your book.